So a patient described this very well, I think. He said, if you reach out at the right time, in the right way, in the right place, and with the right feeling, many who have previously not trusted healthcare providers will accept services. I think that's right. You don't always know what the right time and place all that is, right? Because it was that different for every person. So what you have to be willing to do is try to find out what the right time, right place, right feeling is for each person you're serving, instead of expecting them to acclimate to you or to your operation. So 6 years ago, we started a clinic. We actually started in the Bangor Homeless Shelter. We took a room, divided it in two. We had my colleague, family nurse practitioner, Mary Jude. Anybody know her? She knows everybody. So she's one of the greatest people I know. She and I, we actually wrote a grant and didn't get it, so we said, we'll just do it. And so we started it, and we couldn't do it much because our boss wouldn't let us do it much, but he let us do it enough to get it going. And we worked with Mike Andrick, who was the program director, right, at the Bangor Homeless Shelter, and we all worked together and started a little clinic where we did family practice and psychiatry, and it usually worked something like this. The person would have a runny nose or a rash. They'd want to see the nurse practitioner. Mike would facilitate that process, and during the course of that, the nurse practitioner may discover something that I might be able to help. And she may say something like, well, we have this person here who does mental health. Would you like to just say hello to them? Purpose wasn't an evaluation. It was just to say hello, just to get a start. And from there, we said hello a few more times, sometimes months before we ever sat down. Maybe said hello and talked about the Red Sox, or said hello and talked about the weather or the food, or just how you're doing. But we started with the primary care, we connected that way, and then we went forward. And so then we decided to do a grant for the Rartwood Johnson's Foundation, and we were very fortunate and got that grant, and then we could build a really nice clinic with the money. And we located that clinic a block from the homeless shelter within vision, which is actually very important. That's within sight. Would probably even be better in the shelter, but that couldn't work that out. So we did the best we could with that. And that we've had good luck with that from there. And I'll share our experience. I also want to thank Stephen and Tabitha King, the Bingham Foundation, and the Maine Health Access Foundation. And we were without grant funding for 2 years, so if you'd like to give us more, we're willing to take it. But the good news is we are viable without grant funding. Well, yeah, that's the key. That's the key. And the other key is we're in Maine. And I've not been paid by DHHS, but you couldn't necessarily do this in every state. We're in Maine, and only 26% of our people don't have health insurance. So that's a big difference. But, yeah, go ahead. Yeah, absolutely. Absolutely. Yeah, that is the whole thing. That is the whole thing. And I think we have people around us that are good at that. And I think that's a little more natural with the family doctor, really. They expect that with the family doctor. I think that's really helped. It's not just family doctors, family nurse practitioner, physician assistants. Then the credential's not all that important. It's how you connect with people. So anyway, we were hoping to build a model that could be transferable. And I believe this one can in a federally qualified health center environment in a state similar to Maine or anywhere else in Maine that has a federally qualified health center. And in fact, Preble Street is very similar to what we do. And in fact, Mike and I took a trip to Preble Street when I worked for another job a long time ago when I first moved to Maine to look at how to do a clinic. So we have two good examples of, I think, really good clinics in Maine, and there are probably others. This is our mission. And we kind of focus on this eroding false perceptions thing, because I think that's a key to really finding the solution, which is a home. Have I said that yet? All right. We do all these things under one roof. And that's real important because it's hard to establish trust with us. It's also hard to establish trust anywhere else in the community. We actually even built a couple consult rooms so people could get case management at our place. Now, a lot of times the agencies will ask for the person to come to their place, which is different than what I'm used to anywhere else, but really hard for the homeless person to do that. And I think it's a shame. So we did actually build a couple consult rooms so the agencies could use our consult rooms to see people. Unfortunately, they weren't used. So we still have a ways to go here, I think. But in any case, we do offer all of these things here under one roof, including things like dentistry. We do dental hygiene. If they have a problem, it's identified on the spot. People are sent to our main clinic to see the dentist. And we give them taxi vouchers and make it happen. This day program thing is, we noticed after a couple of years that, yeah, it was great when people got housed, and unfortunately they were usually housed in a section of Bangor that was not very desirable to live in, didn't feel very safe, and they actually felt much more secure at the shelter. So that was one issue. The other issue is we just kind of hung out in the day room at the shelter a couple times and noticed that, golly, this is hard, this is boring. It's hard to do this. And you got to wait 2 months and 3 months and 4 months for everything to fall into place. And hard to stay healthy during that time. So we built a little room in the back of our clinic, and it's not that little. It's about half of this, I guess. And put a pool table. We had a pool table donated. It's all donated stuff, and it's a place to hang out, a place where people can just be. They can feel safe if they are housed, or they can combat boredom when they're not. And I think it's fairly well utilized. I think it was a good idea. It seems to have worked well. So we added that in, and we have a lot of other things. We do rely on a lot of group work, which seems to work really well with the population we're working with. I think it'd probably work with any population if people would go. Works well. People help themselves. The homeless community is very tight. It's a culture, and you've got to work your way into it. Very tight, very giving, very loving people. The chronically homeless know each other. They'll do anything for each other. Even the most psychotic of chronically homeless people, first of the month, they're buying pizzas for everybody. So this says it takes hands to build a house, but only hearts can build a home. So again, we're trying to get at that feeling that the gentleman mentioned in the back earlier today. We ask our patients, we have a patient advisory board, we ask them, what do you think? What are we doing right? What are we doing wrong? These are some quotes they gave me about the model. They're in the handout there. You guys can read better than I can, I'm sure. So, everybody ready to move on from there? You got it? Okay. We also make sure we focus on basic needs with those who are just experiencing homeless and don't have these things met. We start there because that's probably where they're at. So we ask them about food and water and safety and sleep, and we try to help. We have great resources, like Jason here is in our place a lot, and great resources that help us connect to these things. But we ask about that. We're focusing on that. We're not focusing so much on the things that are going to be less important than what you're going to eat today, where you're going to sleep. You got some water. Start there. People come to trust you faster when you start there. So this meet people where they are thing, I think it's non-judgmental compassion. We listen. We try to hear what the person wanted, and we try to solve what they wanted first. Even if what they want is not exactly what we would put as a priority, we try to solve what they wanted first. And if we don't, we're not successful. You're not successful if you don't listen and try to help what they want first. Patient-driven, not disease-driven. Patient control, patient involved, patient-led. We try to maintain that focus. Not always easy to do in fast-paced healthcare clinics, but we work hard to maintain that, and we check each other when we're not.